5 seconds to pause the video, and then we'll go through the answer to the question. Okay, so we upped the difficulty here. Now, one thing I want to say before we start this question, sometimes, on board exams, and this is definitely true for step 1 and step 2, is sometimes you'll get a situation where a lot of the options will be high yield things that you're expected to know, and those will all be the wrong answers. And the only right answer will be something that is more vague, that it's more medium low yield, but the idea is that you're able to rule out all of the stuff you absolutely should know so that you can figure out something you might not completely understand. I don't know if that makes sense, but that tends to be the questions that are the ones that you see people like 25% get correct or 30% get correct, and are sometimes used to stratify people. I know step 1 has the pass-fail thing going on, so there might not be as much stratification, but you're still going to come across questions like this most likely, so just kind of keep this in mind. This is an example of that. Let's just go through it. We have a 44-year-old female coming to the emergency room. She experienced an episode of loss of consciousness with generalized uncontrollable and rhythmic contractions. So this is very classic for a description of a tonic-clonic seizure. Her husband reports that she has been unable to speak well since the incident. Okay, this might be due to Todd's paralysis potentially. Let's see, he believes that she may be embarrassed due to the episode of bladder incontinence she suffered when paramedics arrived. So, a lot of times, I don't want to say this is always true, but in board questions, when they tell you the patient believes this is going on because of this or this, it's usually not what's actually happening, but they're kind of saying that so you can get more information. So he believes that she may be embarrassed because she had an episode of bladder incontinence. Now, this is also very consistent with her seizure episode, and she's probably not speaking well, not because she's embarrassed, but because maybe she has some potentially aphasia or a neurologic deficit, or like I said, Todd's paralysis, secondary to the seizure. Okay, lacerations on the tongue are noted, also consistent with her seizure, and the patient is visibly aphasic. A review of the patient's medical history reveals a history of hypothyroidism, okay, and no history of previous seizure episodes. Okay, like I said, this is very classically how they ask you about brain tumors. They don't have a history of seizures, they just had a seizure. Her husband states that she has no family history of seizures and does not consume alcohol, right? Alcohol, why do they even tell you this? Alcohol can cause you to have seizures. Do you treat seizures if a patient is, consuming alcohol and they go into withdrawals? Okay, very classic, right? You can have DTs, delirium tremens, from alcohol withdrawal. Do you treat DTs with anti-seizure medications? Generally not, because the seizures tend to be provoked secondary to the alcohol. Okay, so a head CT and subsequent biopsy is performed. Okay, so here's the head CT, which we'll talk about in a second, and we also have the biopsy down here. And I also included this in here. Okay, so let's just go through this and see where we're at. So what's your take on this CT? I mean, so obviously here's the mass, right? And the thing about it is, it looks like it's not necessarily just, if the mass was like right here, right, I'd be thinking, okay, maybe GBM, maybe oligodendroma, but the mass, it looks like it's a big portion of it. I'm just wondering where's the rest of it, right? It looks like it's kind of attached in here, right? Almost looks like it's attached into the bone, but it's not going into the bone. It's probably attached to the dural projections, right? The arachnoid specifically, is if it was a meningioma, okay, which makes it really interesting. So let's say that you're thinking, okay, well, maybe it's a oligodendroma. We don't know for sure, right? I'm looking for fried egg appearance on histology. I'm not really seeing it here. I'm seeing this thing, which, to be honest, just looking at it the first time, I'm not really sure what that is. I don't see pseudopalisading. I don't see fried egg appearance. Don't really see chicken wire capillaries. I mean, I would say, okay, so that it's tough. Okay, this is a tough question. Now, what you have to do is, I showed you a Simoma body earlier, but you have to be familiar with multiple different pictures of Simoma bodies. Okay, if you just look at one picture and you say, okay, that's it, I know Simoma bodies, it's not that easy. You can go on Google Images, you can pull up 20 different pictures of Simoma bodies just so you can see what they look like. And this is actually a Simoma body. It depends how it's stained, and there's a lot that goes into it, but this is actually a Simoma body here. It does actually have a bit of a world appearance. And again, you're not always going to get classic histology images, okay? So you usually will. But there's two things that point to meningioma here. The first thing is, this tumor looks like it's coming off of the periphery. Just from this image alone, you can make a case for this being a meningioma. The fact that you have a psammoma body here, we don't have any fried egg appearance, we don't have any palisading or peripheral necrosis, right? So it's very unlikely that this patient has GBM or that this patient has an oligodendroma. So let's go through the options here. So derived from tissue of neuroectoderm. So if it was derived from tissue of neuroectoderm, it would probably be something like GBM, right? GBM would be an example of tissue derived from neuroectoderm, right? So this is not the case. Meningiomas are derived from the neural crest cell origin. And you might be saying, well, how did you come to that conclusion? So remember, we had a video on this, right? So I took the picture and I put it here for you previously in this series. The arachnoid tissue is derived from neural crest cells. Where do meningiomas come from? The arachnoid tissue, right? So sometimes things aren't going to be laid out perfectly for you. You have to put some concepts together. And I said, this is a difficult question, but that's the idea here, right? You know they're from the arachnoid tissue, so we know they're derived from neural crest cells. And in real life, meningiomas actually stain S100 positive sometimes. In a board question, it really wouldn't be fair to ask that, because when you say S100 positive, we're usually talking about vestibular schwannomas or malignant melanoma. But it could test positive because it's from neural crest cell origin. Okay, so just putting the pieces together. Glial fibrillary acidic protein positive. This would be very classic for glial tumors like we talked about. This would be like a pilocytic astrocytoma or a GBM. But remember, meningiomas do not come from glial origin. Synaptophysin positive is for neuroendocrine tumors. Strong staining for CD20 would be classic for primary CNS lymphoma because it originates from B cells. Okay, so most likely this tumor is meningioma based on its location here on imaging, as well as the psammoma body that we identified here. And even if you didn't put this piece together that it's from neural crest cell origin, you can start to rule out the other options if you understand what these tumor markers and tissue derivatives are.